All right, page 1305 on the trauma and the geriatric patients. In general, the risk of serious injury or death is more common in older patients who experience trauma than in younger patients. Conditions that create risk and complicate the assessment of geriatric patients include slower hemostatic compensatory mechanism, limited psychological reserves, no effect of aging on the body, and existing medical issues. Physical findings can be easily missed because the healing process is longer. Older pedestrians are more likely to have life-threatening complications, that being struck by a vehicle. And secondary impacts can also cause serious injuries. Older people have higher risk of burn injuries because of altered mental status, inattention, and a compromised neurologic status. Risk of mortality from burns is increased when pre-existing medical conditions exist. The immune system is weakened and fluid replacement is complicated by renal compromise. There is a higher mortality rate from penetrating trauma in older adults, and penetrating trauma can easily cause serious internal bleeding. Falls are the leading cause of fatal and non-fatal injuries in older adults, and nearly half of fatal falls in geriatric patients result in traumatic brain injury. All right, anatomic changes and fractures, 1305. Changes in pulmonary, cardiovascular, neurologic, and musculoskeletal systems make older patients more susceptible to trauma. The brain shrinks, leading to a higher risk of cerebral bleeding following head trauma. Skeletal changes cause curvature of the upper spine that often requires additional padding during spinal immobilization. Loss of strength, sensory impairment, and medical illness all increase the risk of falls. A geriatric patient's overall physical condition may lessen the ability of the patient's body to compensate for the effects of even simple injuries. Osteoporosis predisposes older patients to hip and pelvic fractures. Compression fractures of the spine are more likely to occur. As the brain tissue shrinks with age, older patients are more likely to sustain closed head injuries such as subdural hematomas. Acute subdural hematomas are among the most deadliest of all head injuries. Serious head injuries are often missed in older patients because the mechanism may seem relatively minor, and other factors that predispose an older patient to a head injury include those on page, the last paragraph, right there above, environmental injury. All right, moving under environmental injury, changes in endocrine system results in delayed internal temperature regulation. Heat gain and loss is further delayed from impairment, circulation, decreased sweat production, chronic diseases, medical use, and alcohol use. Half of all deaths from hypothermia occur in older people. Most indoor hypothermic deaths involve geriatric patients. And death rates from hypothermic more than double in older people compared with young people. And people older than 85 years old are the highest at risk. And under special consideration assessing the geriatric trauma patients, I'm going to go ahead and let y'all read that for yourself. Then we'll move on along to assessment of falls on page 1309. Don't overlook medical conditions such as fainting, a cardiac rhythm disturbance, or medication in reaction as a cause for a fall. Whenever you assess a geriatric patient who has fallen, it is important to find out why the fall occurred. Look carefully for clues from the patient, bystanders, and the environment. All right, page 1310. Response to nursing and skilled care facilities. Many calls will occur at a nursing home or other skilled care facility. Calls to these types of facilities can sometimes be challenging. Patients often have an altered level of consciousness and may not be able to give you the nature of illness or mechanism of injury. The most important piece of information you need to establish immediately is what is wrong with the patient that is new or different today that made you call 911. Talk to the staff who directly care for the patient on a daily basis. Infection control needs to be a priority for the EMTs when visiting these facilities. An infection in an older patient can lead to life-threatening sepsis. MRSA infections are common among people who are living in close quarters, such as nursing homes. The organism can be found in ulcers on feeding tubes and in indwelling urinary catheters. And protect yourself and reduce the spread of MRSA infection, you should wash your hands before and after every patient contact. Many infections in hospitals are caused by VRE, and RSV causes an infection of the upper and lower respiratory tracts. The virus is highly contagious and is found in discharges from the nose and throat of an infected person. So always wear appropriate PPE and decontaminate your ambulance and diagnosis equipment. C. diff is a bacterium responsible for most common cause of hospital-acquired infectious diarrhea, and healthcare workers may carry this bacterium following contact with contaminated feces. And remember that typical alcohol-based hand sanitizers do not inactivate or kill C. diff. All right, 1311, dying patients. As older patients are living longer, more terminally ill patients are choosing to die at home rather than the hospital. Dying patients receive what's called palliative or comfort care. This focuses on relieving pain, providing emotional support and comfort for the patient, for his or her loved ones. Your interaction with a dying patient will have long-term effects on the family, so be understanding, sensitive, and compassionate. All right, looking under advanced directives. Advanced directives are specific legal papers that direct relatives and caregivers about what kind of medical treatment may be given to the patient who cannot speak for themselves. Advanced directive may take the form of a do not resuscitate order, or a DNR. All right. Under DNR, something I want you to remember, that a DNR gives you permission not to attempt resuscitation for a patient in cardiac arrest. For a DNR order to be valid, the form must be signed by the patient or legal guardian, or by one or more physicians or a licensed healthcare provider. DNR does not mean do not treat. If the patient is still alive, you are obligated to provide supportive measures that include oxygen delivery, pain relief, and comfort. If there is any question regarding orders, or when there are no written orders, initiate resuscitation. Now, if you go on a call and a person is in cardiac arrest and a family member says that he has a DNR, if that family member cannot present you with a DNR, you start resuscitation until that family member can present you with a DNR. All right, elder abuse and neglect, page 1313. All right, I want you to read this for yourself, but under assessment of elder abuse on page 1313, where it says information that may be important to assessing possible abuse include the following. Remember those, and also remember those on page 1314, table 13.5. And I hope to see y'all soon. So until then, each and every one of y'all stay safe.